I was tasked to talk a little bit about therapeutics for COVID-19, what we know and what we don't. And I've emphasized what we don't know because I think it's worth highlighting that the current treatment of COVID is supportive therapy. And as Dr. Svensson mentioned at the outset, there are no FDA-approved investigations, so I think we have to be very careful in this changing landscape about what we talk about when we talk about standard of care in COVID-19. And related to that, I have a few disclaimers at the beginning of my talk. And one, as we all know, that the understanding of COVID-19 is rapidly evolving. What we know now is very different than what we knew even 1-2 weeks ago. Secondly, we've been inundated with anecdotes, case reports, and single-center retrospective observational cohort studies, which are all helpful but have noted limitations. And related to this, the typical peer review process has been accelerated or even bypassed. I think we can add, at least for me, the word preprint to a word that I didn't know a couple months ago. So I think a good place to start in terms of what's going on in research in COVID-19 is clinicaltrials.gov. So as of yesterday, there's nearly 700 studies that are registered. 2/3 of those are interventional studies, so those are clinical trials. However, it's worth noting that the number of studies actively recruiting currently in the US remains quite small at only 7%. And you can look at clinicaltrials.gov and get a sense of the lines of investigation that various colleagues are pursuing. And it's, as Dr. Menon mentioned, it's protein. But as it relates to cardiovascular medicine, I think we can focus on a few key areas: the ACE inhibitors, the ARBs, the antivirals, antiplatelets, anticoagulants, and I'll spend most of my time addressing the potential role of immunosuppressives. All right, so this is the paradigm that we've come to recognize in COVID-19, that there's really 3 stages, that there's initial asymptomatic stage with a prominent viral response, that patients then progress to a second stage where they have non-severe disease but are symptomatic, and there's a subset of patients, unfortunately, that develop severe inflammation characterized by the so-called cytokine storm. And I think an important concept is that the treatments that are appropriate may be different in different stages of the disease. So for stage 2, we may focus on antivirals and viral clearance. And in stage 3, in the later stage hyperinflammatory phase, we may focus on immunosuppressives or immunomodulatory agents. So there may be drugs that actually work in terms of viral clearance early in the disease, but are actually deleterious in the later stage of severe inflammation. So how do we think about COVID-19 and hyperinflammation? I think it's useful, this construct of the continuum of immunological disorders from the innate to adaptive immune response, and thinking in terms of loss and gain of function. Because for me as a cardiologist, I always was confused how a disease like primary HLH, which is an immunodeficient condition, actually leads to profound hyperinflammation. And in the context of COVID-19, how could that potentially happen? Well, coronaviruses can downregulate interferons. Okay, so this would be a loss of function in relative immunodeficient condition. But that results in a secondary wave of macrophage infiltration and inappropriate upregulation of the innate immune system with cytokines such as interleukin-1, interleukin-6, GM-CSF, et cetera. Conversely, we can just be revved up the entire time from the outset. So I think this is an important concept in terms of how do most patients get to this in hyperinflammatory state? Is it an initial immunodeficiency condition related to the virus, or are some people just hyperactive throughout the course? As it relates to cardiac manifestations, there's really 3 questions that come to mind, some of which have been touched upon. Is that, 1, what is the mechanism of SARS-CoV-2 myocardial damage? 2, to what extent are these patients a distinct population? And then finally, what are our treatment options? So just to take a step back, how do we define acute cardiac injury? Well, it's been defined in the past in viral studies fairly broadly, just simply as an elevation in serum cardiac markers. And as Dr. Menon mentioned, in the early observational cohort studies in COVID-19, the reported incidence ranges from 8 to 28%. Now, I think for us as cardiologists, we're very familiar with this, but it's worth emphasizing that we should distinguish myocardial infarction, so that is injury associated with ischemic signs and symptoms, from myocardial injury, which is a rise and fall of troponin without ischemia. And as we'll mention, viruses are well known to precipitate both myocardial infarction and acute myocardial injury, though, however, it hasn't been in the past too common to see these manifestations with other coronaviruses. So, for example, with SARS, which has a case fatality rate of around 10%, cardiac complications are limited to case reports or series. And there's a similar observation with MERS, where you can find case reports, but hasn't really featured predominantly in the disease. And so already there's been a couple of case reports related to fulminant myocarditis in COVID-19, similar to the case that Dr. Goal presented at the outset. So you can see a case of perimyocarditis. This is a case of fulminant myocarditis with acute lymphocytic myocarditis on histology. But I think an important point, at least to my knowledge, unlike the slide of the lungs that Dr. Menon showed, I don't know that we've yet demonstrated viral genome in an endomyocardial biopsy specimen. So it's not really clear what's going on in terms of the myocarditis in COVID-19. And while I think it can be a presentation, it seems to be a minority of patients. And also, as Dr. Menon mentioned, the ACE2 receptor seems to be important. However, this is something we've known from SARS-CoV-1. And it's important that we recognize that the downregulation of the ACE2 receptor can lead to unopposed upregulation of angiotensin II, and that's why there's some investigations actually looking at ARBs in the treatment of COVID-19. But all that said, a lot of these patients do progress to a hyperinflammatory state as a primary cause for their demise. And there's multiple factors that contribute to this so-called cytokine storm or macrophage activation syndrome that likely include a genetic predisposition that's heretofore undefined, some background inflammatory activity, the infectious trigger, and then inappropriate activation of the innate immune system. So here's some data from an initial preprint in China, looking at cytokine and chemokine profiles in patients in the ICU or not in the ICU with COVID-19. And again, this is preliminary data, but is similar to what's been previously observed in other coronaviruses. And that is that the patients that are sicker have higher levels of inflammatory monocytes, expressions of GM-CSF and IL-6, and also, secondly, have pathological activation of type 1 T helper cells in COVID-19. And we know that these patients that are hyperinflamed are more likely to die from COVID-19. They have higher levels of CRP, IL-6, ferritin, and AST. So then the second question is, to what extent are these patients with myocardial damage a distinct population? Well, we know that there's more prevalent cardiovascular comorbidities, including coronary disease, chronic heart failure, hypertension, diabetes mellitus, and obesity. And this idea does support myocardial oxygen supply and demand mismatch with ischemia in a vulnerable population. But I'd like to highlight a couple of points. This slide is one that Dr. Menon already showed, which shows that, yes, the highest mortality is in the patients who have established cardiovascular disease with an elevated troponin. But what's interesting is even in patients who don't have known cardiovascular disease and elevated troponin, the initial mortality rates have been quite high. So that would suggest that this is not being entirely driven by the comorbidities. The second point is that there is a correlation between this elevation in the CRP and the elevation in the troponin. And what you can see, at least in the initial reports, is that the majority of patients who have an elevated troponin also have quite marked elevations in C-reactive proteins. So I think this construct is helpful in how we think of myocardial damage in COVID-19, is that I think as cardiologists, we're used to thinking about the ischemia signs and symptoms, but we should also be thinking about hyperinflation in our patients. And I would say that a lot of the patients who have elevated troponin, given the very high mortality rates we've seen, around 50% in initial reports, that a lot of these patients are in this final stage of hyperinflammation related to COVID-19. So what do we know about potential treatments to block this inappropriate activation of the innate immune system? Well, for over 25 years, we've been using, or at least 25 years ago, we used interleukin-1 antagonism in severe sepsis. This is data from a randomized controlled trial of nearly 900 patients using anakinra. And what I would note is, even though there was no difference in mortality overall in patients with severe sepsis, in further subgroup or hypothesis-generating types of analyses, there were differences seen in patients who had organ dysfunction or who had features of secondary HLH. The other thing that's important to know is that there was no difference in serious adverse events in the use of interleukin-1 antagonist, even at very, very high doses in these studies, much higher than what we typically use now for rheumatoid arthritis or in my field in recurrent pericarditis. So what randomized controlled trials are currently being performed with immunosuppressives in COVID-19? So we have randomized controlled trials with the interleukin-6 antagonist. We have trials going on with anakinra, GM-CSF antagonist, and actual multiple studies that involve colchicine, which inhibits tubulin polymerization and inflammasome activity. So based upon this underlying biological plausibility of hyperinflammation leading to demise and inappropriate activation of the innate immune system, we have an FDA-approved investigator-initiated study here at the Cleveland Clinic looking at acute myocardial injury. It's a placebo-controlled randomized controlled trial using canakinumab, which is an interleukin-1 antagonist. That's specific to patients who have acute myocardial injury with elevated troponin, elevated NT-proBNP, and elevated CRP. So to conclude, we're used to thinking about signs and symptoms of ischemia, but I think in myocardial injury in COVID, to risk stratify, we also need to think about the features of hyperinflammation, and that these patients tend to have more cardiovascular comorbidities and higher CRPs. And I think that the therapies that target the innate immune system and inflammasome may be effective in this setting.